Greetings from Jabalpur. I'll be talking on endoscopic approach in cervical disc disease, that is disc preserving surgery. Anterior cervical decompression and fusion is a standard surgical procedure in the cervical disc diseases. ACDF is usually safe and effective surgery and has been practiced over the years. But there are some limitations of ACDF, and those are loss of disc height, there is pseudoarthrosis, there is a degeneration of the adjacent segment. The other treatment option for cervical disc disease is endoscopic approach from anterior side, which preserves most of the disc. It is effective in radiculopathy and also in myelopathy. The advantage of endoscopic anterior approaches are that the fusion is not required. It preserves the motion segment because only part of the disc is removed and most of the natural disc is there. So it preserves most of the natural disc. The manipulation of the cervical nerve root is not required when compression is anteriorly placed. You can see in this diagram that this radiculopathy or even the myelopathy, if the compression is from anterior side, that is from either a disc protrusion or there is an osteophyte from the adjacent vertebral body, or there is OPLL. In such case, when there is a compression from anterior side, it is better to go from the anterior side. The indications are when there is a significant anterior compression, whether it is radiculopathy, myelopathy, or myeloradiculopathy due to disc osteophyte from the vertebral body. It can be done in presence of straight spine, and up to 2-level disc disease can be addressed very well. The contraindications are significant posterior compression, that is when there is a hypertrophy of the ligament flavum or there is a facet joint hypertrophy. There is congenital canal stenosis, significantly reduced disc space with terminal stenosis. In such cases, it is better to place in the graft and go for stabilization and fusion. There is unstable spine. The relative contraindications are compression of more than 2 level, although it can be addressed, but the operative time increases. There is a dense OPLL, which is adherent to the dura, and in such cases, you find a double layer sign. As seen in this diagram, there is vertebral body, there is a OPLL. So in between there is hypodensity. So in such cases, the OPLL is integrated into the dura and there is some portion of intradural element also in OPL. And in such cases, there is a risk of CSF leak if you go and take the anterior approach. Disc migration, which extends more than the half vertebral body above and or below. So in such cases, you need to remove the vertebral body also, part of the vertebral body. The previous operation at the same site is also relative contraindication. Now, a word about anterior or posterior approach, which cases we should go from anterior side. So simple rule is this is the root or the cord is here. So in any case, if the compression is from the disc or the osteophyte or there's a OPLL, so any lesion which is lying anterior to the cord or the root should be better approached by anterior approach. But if the lesion is posterior to the cord or to the root, like in this case, if there is a facet hypertrophy or there is a ligamentum flavum hypertrophy, in such case, the posterior approach is ideal. One more exception from of the posterior approach is that if you have a soft disc which is extremely lateral, means at the lateral margin of the cord, within that 5 millimeter, if there is a soft disc present, then you can also go from the posterior side. The approach which should be taken in these cases could be the lateral approach, like shown here. You can go from the lateralmost side of the disc, but this is indicated only for radiculopathy. If there is a myelopathy or myeloradiculopathy, it is better to take the central approach. That means you go from the middle of the disc space. There are people who have shown that even from the lateral approach, you can decompress the cord also by angulating the tubular retractor. So this is also possible, but it is better to go from the central approach if you have myelopathy along with the radiculopathy. In the procedure, one should localize where is the site of pathology using localizer, which are commercially available. So localize the site, and then the surgery is performed under general anesthesia. About 3 centimeter skin incision medial to the sternocleidomastoid is given. The neck is slightly extended. It is done in the supine position with or without traction, and the approach should be from the symptomatic side. If there is a radiculopathy on the right side, you go from the right side. If it is on the left side, go from the left side. But if there is a symmetrical compression from the central, then you can choose the right side approach for right-handed surgeons. And right side approach if the disc migrate more cranially. If there is a cranial migration of the disc, then you should prefer the right side approach, because working cranially for a right-handed person from the right side is easier. On the other hand, if the disc is migrated caudally, then you should take a left side approach. This is for the right-handed surgeon because of the easy working. This may not be true for left-handed surgeon. You should localize it again, confirm the correct disc level again by putting in a LP needle which is bent at the tip, only about 1 centimeter distal, and can be pierced by bending this. So again, localize the correct disc level and mark that level. I have already discussed that if there's a unilateral only radiculopathy, then you can take a lateral approach from the lateralmost part of the disc and using the uncinate process and the uncus on the lateral side. But if there's a myeloradiculopathy of central disc, then you should go and take the central approach. And how to remove the all compressive force. This is the example, just pictorial explanation of how you should decompress the whole cord and including root, removing only a part of the disc. So remove only a part of the disc, which may be about 5 millimeter in size, removal of part of the anterior portion or part of the posterior portion of the disc or the vertebral body. If you remove it, then you can angulate it more. So rather than taking out most of the disc or the vertebral body, only a part of the anterior portion of the disc along with that 5 millimeter corridor, you can remove most of the posterior portion, which is the culprit, and pressing on the cord and the root. The second help one can take is that you should use angled curate or angled instrument. So angle Garrison punch or angled curate, if you use, then only a culprit portion of the disc material or the osteophyte can be removed. So this is the example. If you go a straight line without removal of the anterior part of the vertebral body, then you can only approach up to here. So this compression may still be present. So using the angle instrument and removal of little bit of the anterior portion and little bit of the posterior portion, which is adjoining this, the cord and the root, you can angulate it optimally and remove all the compression. All steps are same as the standard ACDF procedure. Until exposure of the disc, we use microscope or VTOM. The endoscope is brought after the exposure of the desired disc. This is a small video of the procedure, the disc preserving surgery using anterior approach. This was C4, C5 central disc. You can see the big osteophyte and the calcified disc, the central portion of the disc and the adjoining anterior longitudinal ligament is coagulated, and then part of the disc and the adjoining vertebral body, adjoining vertebral body superiorly and inferiorly, that is C4, inferior portion of the C4 and the upper portion of C5 is drilled. The disc, part of the disc is removed, and further drilling until you find only a small portion of ant cartilage is visualized. You can see that now the decompression, only a soft portion is left. The ant cartilage, the disc, all these things have been removed, and then using a small 1 millimeter Garrison punch, that ant cartilage is removed. This is a big fragment which is compressing in the cord, is gradually and gently removed. The big fragment which was compressing the cord has been removed, and after this you can see that the cord pulsations can be visualized very well. Further decompression until you are satisfied. I always remove the PLL because there may be subligamental herniated disc fragment. So further removal of this soft tissue, and in the end one can visualize that well pulsating cord. Then you can finally go for absolute hemostasis and put in a small piece of gel foam, and that is the end of surgery. This is the preoperative MRI which shows C6, C7 lateral disc, preoperative MRI, axial cut showing compression on the root. This is the post-operative MRI showing good decompression, and this is a reconstructed image which shows the amount of disc removal and the amount of adjoining bone removal, adjoining vertebral body removal. This is another case of C4, C5 disc prolapse, preoperative MRI, the compression, the central disc, the amount of bone removal, very small part of the disc, and they are joining vertebral body. And here, this is essence of the surgery. The anterior portion of the disc removal is small, whereas the posterior portion towards the root and the cord, the part of the vertebral body, the adjacent portion, the inferior part of the superior vertebral body and the superior part of the inferior vertebral body, they are drilled little more, so that all compressive force which are compressing on the root and the cord is removed. And this is the amount of disc and the vertebral body removal. This you can see that the alignment is maintained after surgery, and this is the amount of disc and the vertebral body removal. So the results, it is effective and safe in myelopathy and radiculopathy in more than 1,000 cases. We have done over 10 years period, but there are some rare complications, especially in the beginning of your learning curve. There may be hematoma, so absolute hemostasis should be achieved before you close. There may be esophageal injury, there may be vertebral artery injury. I saw one case of vertebral artery injury in my experience. After that, I do not remove 1 to 2 millimeter of lateral portion of the vertebral body, the uncinate process. So that portion is left behind, which protects vertebral artery and the oozing from the venous plexus. So a lot of oozing from the venous plexus plus the vertebral artery injury can be avoided if you leave 1 to 2 millimeter of that bone which protects the vertebral artery. There may be root injury that is also rare, especially C5 root palsy. The neurological deterioration may be there. There may be reoperation if you don't decompress it well. There are limitations. There is a decrease in the disc height because some of the disc material is removed, but this has not affected the ultimate long-term prognosis. Even if there is a settlement of the disc, it did not matter as far as the patient status is concerned, even in the long-term follow-up which we have now. There is a possibility of recurrence and there is a difficult learning curve. So to conclude, endoscopic decompression using anterior approach is an effective alternative to decompress the cord or root up to 2 level. Although it is difficult to learn, but it is safe once sufficient experience is gained in the endoscopic surgery. We have started the 1-year university certified neuroendoscopy fellowship program and 1 week neuroendoscopy fellowship training, which we conduct 6 monthly in March and September for the last 15 years. Thank you very much, and I thank to my teachers. Thank you.